I'll now start introducing the next speaker, which is me. And as you saw, I'm from Toronto, from St. Michael's Hospital, Keenan Research Center, Li Ka-shing Knowledge Institute of St. Michael's Hospital. And what I'm going to talk about today, this morning, is to talk about causes of ventilator-induced lung injury and its progression to a general inflammatory response. So not just focus on what mechanical ventilation does to the lung, which is clearly important, and the injury it can cause, but also some of the systemic effects that can be caused by mechanical ventilation. So in terms of what I'll be covering in the next half hour, I'll give you a brief historical overview, a very brief historical overview, just really sort of giving you an idea of a case report that appeared a number of years ago in the literature. I'll then talk about some current concepts related to ventilator-induced lung injury, barotrauma, volutrauma, atelectrauma, and biotrauma, and I'll describe these as I go along. I'm not going to focus on the effects of the vasculature on ventilator-induced lung injury, which is likely important, and John Marini is going to talk about that, and as is Fernando Sipman. And then I'll focus, spend a fair bit of time on the systemic consequences of ventilator-induced lung injury and some of the implications of the systemic consequences. So let me start with this case report, which appeared in the literature a few years ago. This is from the Philosophical Transposition of the Royal Society of Medicine. That 1744 at the end is not the page number, that's the year that this was published. This is an article published 2.5 centuries ago, and it's observations on a case published in the last volume of the Medical Essays. That's the sort of old English writing of a case recovering a man dead in appearance by distending the lungs with air. So printed in Edinburgh in 1744. And this had to do with a physician by the name of Tossack, and this quote is taken directly from that article. It said, Tossack came upon a man who had suffocated because of fumes from a coal pit. So that's a cause of acute respiratory failure or arrest. And he found this patient who was not breathing, who was pulseless. And what Tossack did, and this was pretty unusual at the time. I mean, we look at CPR now as sort of a standard approach to the unconscious patient or to a patient who's not breathing and lifeless. But what Tossack did was he applied his mouth close to the patient's, and by blowing strongly raised his chest fully. He immediately felt 6 or 7 quick beats of the heart. In 1 hour, the patient began to come to himself. Within 4 hours, he walked home, and in as many days returned to work. Pretty successful resuscitation. So that in and of itself is pretty interesting, because resuscitation back in the 18th century was really not an approach that was done by modern approaches. And I don't have time to talk about some of the approaches that were used, but this was an unusual approach. But the reason I'm telling you about this case was the discussion was interesting. Because in the discussion, the author said some had suggested a bellows, that is, instead of using mouth-to-mouth resuscitation, use a bellows. So that is, sort of forcing gas in with a bellows at a constant flow. But he said, but blowing would be preferable. So mouth-to-mouth resuscitation would be preferable, as the lungs of one man may bear, without injury, as great a force as those of another man, which by the bellows cannot always be determined. So what he was saying was that better to use mouth-to-mouth resuscitation, because when you use a bellows, you don't know the pressures you're using. You can generate extremely high pressures, and you might actually injure the lungs by doing the resuscitation procedure. So this is, I think, a prescient article, 2.5 centuries ago, really describing ventilator-induced lung injury, or the concept of ventilator-induced lung injury. Now, nowadays, we're not too worried about patients being exposed to coal fumes, although that happens. But one of the common causes of respiratory failure that's difficult to ventilate patients are those with ARDS. And as you know, this is a syndrome that's characterized by wet lungs. The lungs are stiff. Patients have severe hypoxemia, and essentially they all require mechanical ventilation or they're going to die. So mechanical ventilation is critical. It's also a disease in which pathology is associated with inflammatory responses. And this will become important, as you see, as I go on to talk a little bit. From an epidemiologic perspective, the mortality is relatively high still, well, it's very high in fact, probably about 35+% in all comers. Trials have lower mortality rates, but those are, they have special inclusion and exclusion criteria. And the interesting part, which we've known for about 20 years, is most patients who die with ARDS don't die of hypoxemia. They die due to multiple system organ dysfunction, or multi-system organ failure. And this has been a bit of a puzzle. Why does that occur? And what I'm going to present over the next few minutes is maybe, in fact, that multiple system organ failure is indeed related to mechanical ventilation that's life-saving on day 1, may lead to a problem on day 10 or 15 that leads to the demise of the patient. So let me tell you about a few types of ventilator-induced lung injury. And the first two types are barotrauma and volutrauma. By barotrauma, I mean gross air leaks such as pneumothorax, subcutaneous emphysema, etc. One of the first studies that addressed the mechanisms of this type of injury was by Macklin and Macklin, two Canadians actually, who noted that the alveoli are in close proximity to the bronchovesicular sheath, shown here, and that if you get a pressure gradient across this sheath, it could break, could tear the sheath. That could cause air to go into the bronchovesicular sheath, travel approximately and outwards, and give you many of the manifestations that we know as pneumothorax, subcutaneous emphysema, basically barotrauma. Now, one of the first studies that looked at the effect of high pressures or high volumes, really, on ventilator-induced lung injury was a classic study by Webb and Tierney, and I wouldn't be surprised if we see this slide in other presentations, because it was published over 30 years ago, a great example of a physiology study looking at the impact of ventilation on acute lung injury. These are 3 lungs taken from rats after about an hour of ventilation. You can see these 3 lungs. You can see this lung here is edematous. It almost looks like a liver. It's so full of fluid. And these lungs were ventilated with the following pressures. The peak inspiratory pressure on this lung was 14, 45, and 45. You can wonder why were this lung clearly looks much better than this lung. The difference here being the PEEP level here was 0 and the PEEP level here was 10. So PEEP of 10 was protective. And you're going to be seeing a number of the speakers are going to be talking about PEEP and how PEEP can be protective in terms of ventilator-induced lung injury. But I think a very nice study showing that just mechanical ventilation, these were healthy rats to start. Within an hour at the high pressures and 0 PEEP, most of these animals died of respiratory failure. The key issue here in terms of the mechanism of injury or the factor leading to injury is lung stretch, not the pressure per se. And this was shown very nicely by some work by Didier Dreyfus, now published almost 20 years ago. In this model, they used rats that were ventilated either with high pressure and high volume, that is, they used a high tidal volume that generated the high pressures, or they used high pressure and low volume. And by this, they used high pressure, but they used low tidal volumes, and the way they were able to get the high pressure was to put a binder around the chest wall. So by putting a binder around the chest wall, it increased the stiffness of the respiratory system. A small tidal volume was associated with a high airway pressure. And as you can see here, this is wet weight to dry weight ratio. That was very high in the animals ventilated with a high tidal volume, relatively normal and low in the other animals ventilated with high pressure but low tidal volume. So this showed that what's important here is lung stretch, not in fact the pressures per se. Not surprising, because what's important is the transpulmonary pressure, how much the lung gets stretched. So if we think at the bedside, what pressures do we measure and how can this be used? We often measure peak inspiratory pressure, which represents, that's a pressure somewhere at the airway opening, represents a number of things going into the lung. The issue with peak inspiratory pressure is that it doesn't just tell you about how much the lung is stretched. It increases if the resistance of the endotracheal tube or airways increases. It increases with increases in flow rate. It also increases with changes in chest wall stiffness. So the other approach is to, instead of using peak inspiratory pressure, use plateau pressure. And plateau pressure is better in that you don't have to worry about the resistance factors, But chest wall stiffness, if you have a stiff chest wall, and chest wall in pulmonary physiology terms means not just the rib cage but the abdomen. So in patients, for example, with ascites, they have a very stiff chest wall. You'll get high peak inspiratory pressures. That doesn't mean that that patient is at risk for at increased risk for ventilator-induced lung injury. So a better pressure to use, but is not used routinely, is in fact transpulmonary pressure. And there's a study in critical care medicine by Talmor this year or last year looking at pleural pressure and transpulmonary pressure. It's not an easy thing to interpret. It's not so difficult to measure, but it's not an easy thing to interpret. But I think that's one of the most important factors. Now that's ventilation at high lung volumes. So it can cause gross barotrauma, it can cause diffuse alveolar damage and edema, as I showed you. There's also evidence of ventilation at low lung volumes can cause lung injury. And this, I'll show you schematically, this is a pressure volume curve of the lung, pressure on the x-axis, volume on the y-axis. In fact, this is from an animal, but you can get similar but not identical pressure volume curves from patients. These pressure volume curves have an inflation limb and a deflation limb, which are different, and the difference represents the hysteresis of the lung. There's also an inflection point. This is thought to represent where airways start to open up, and it's important that this represents where they start to open up. Just a little above this point, they are not open yet. They are opening the entire length of this pressure volume curve, of the inflation limb. And ventilation that occurs from below to above that inflection point, or opening and closing of lung units, can lead to lung injury. And there's a number of studies that have addressed this. And I'll just show you one, I think, or two studies. One of the first studies was by Sandhar and colleagues, published, again, almost 20 years ago. And the purpose of their study was to examine whether using PEEP above the inflection point would reduce lung injury. So to try and prevent this opening and closing. They used a lung lavage model in rabbits, commonly used model of infant respiratory distress syndrome. The animals are ventilated with conventional mechanical ventilation. Peak pressure was measured, and what they did was to try and maintain hemodynamics constant between the two groups. As you can see here, they used two different ventilatory profiles, or airway pressure versus time profiles. The first was, get rid of that. The mouse is a little sensitive here. The first was they used an IU ratio of 2.7 to 1, as you can see here. PEEP very low of about 1 or 2, and peak inspiratory pressure. Sorry about that. As I said, this mouse is pretty sensitive. And then in the second group, they used roughly the same peak pressure, higher PEEP, and we'll get rid of that. So for the next speakers, be careful when you're using this mouse here. So the mean airway pressure is constant, and that means hemodynamics are roughly the same. The difference then being the amount of PEEP used. And what they found was, and we'll go on to the next slide now, this is effect of PEEP on hyaline membranes in these rabbits. And this represents here hyaline membranes. Each one of these boxes represents a separate animal. This is the high PEEP group. And the other represents, I'll just show you on this. That'll show them. That'll show that mouse. This represents the low PEEP group, and you can see the hyaline membrane numbers are much higher. So 0 is 0 hyaline membranes, 4 is lots of hyaline membranes. This group, well, the trouble is there's two screens, yeah, 2 pointers, yeah, ambidextrous. So, but the point here is that you can see that the hyaline membranes are much greater in the group ventilated with the low PEEP. So this showed that the use of high PEEP, mean airway pressure was the same, had a marked effect on ventilator-induced lung injury, decreasing ventilator-induced lung injury substantially. Now, there have been many other studies, and I just don't have time in the half hour to show you those studies. We can talk about some of those afterwards if you like, or at the break, but there are many studies showing that if you use 0 PEEP, that can lead to a lot more injury than if using PEEP of sort of 5 or 10 or more. So if I summarize the physical factors causing or aggravating lung injury, there is ventilation at high lung volume, volutrauma or barotrauma, that causes increased alveolar capillary permeability. There's also injury, atelectrauma, that occurs at low lung volumes by recruitment of the lung, by effects on surfactant, and other mechanisms as well. The specific mechanisms are not entirely clear. There's another form of injury, biotrauma, which I'm going to focus on for the rest of the talk. And that's a mechanism of injury that's relatively new, sort of over the past 10 years. And the concept here is that mechanical ventilation can lead not just to this biophysical injury, but can lead to release of mediators. And these mediators can, if they get released, can have effects on the lung, and as you'll see, may have effects that, more than on the lung. We started examining this hypothesis, as I said, about 10 years ago. And the hypothesis we first set out to examine was injurious ventilatory strategy. Those are strategies that overstretch the lung and allow the lung to recruit and de-recruit, can lead to an increase specifically in inflammatory cytokines. And to examine this, we used an isolated rat lung model. And the reason we used this is a model in which we take rats out of the lung, hang them, and ventilate them for a couple of hours. And the reason we use this model rather than in vivo model, it allows us to use relatively large tidal volumes without affecting hemodynamics. And hemodynamics is important. If we're looking at mediators, we know that hypotension and shock can lead to increase in mediators. So we wanted a model to get away from that. It also allowed us to amplify this recruitment, de-recruitment, because in an open chest model, the lung at end expiration collapses completely. So it's an amplification factor. And models are models. It's not a perfect model, but I think it has some relevance, and you'll see that to the human condition. So here are the 4 ventilatory strategies we used. We used a relatively low tidal volume of 7 ml per kilo, 3 of PEEP. Then we used a higher tidal volume of 15 ml per kilo, 10 of PEEP. And then the same tidal volume without PEEP. And finally, a tidal volume of 40 ml per kilo and 0 PEEP. Now, this 40 ml per kilo, you can say, is crazy because, you never use 40 ml per kilo in a patient. But I think it's important to remember, if you think about CT scans of patients with ARDS, they often have parts of the lung that are just not available for ventilation. They're consolidated, collapsed. And some patients can have 3/4 of the lung just socked in, not available for ventilation. In a patient like that, if you use 10 ml per kilo and it goes to 1/4 of the lung, the regional overdistension, that's what's important, the regional overdistension, would be the same as if you gave a healthy lung 40 ml per kilo. So I'm not saying this is completely relevant, but it certainly has some relevance. And after ventilating these lungs for 4 hours, we measured a number of cytokines. This is shown here. This is tumor necrosis factor alpha, a key mediator in the sepsis cascade. A very important mediator. And as you can see, under control conditions, relatively low levels of TNF alpha in the lung lavage, higher levels with medium volume high PEEP, so PEEP was protective, and medium volume 0 PEEP had even higher levels. So overstretching the lung caused release of these cytokines. Look what happened when we combined these two. That's the purple or magenta shown there. That axis is broken at so that represents 1200. That's about a 50-fold or 60-fold increase in TNF just due to 2 hours of mechanical ventilation. So showing that a strategy that affects the mechanics, that overstretches the lung and allows the lung to de-recruit, can have a marked increase in release of an inflammatory mediator. Now, studies like this have been reproduced by a number of groups. Well, there's 1 or 2 studies that have not reproduced it, but by and large, these kind of data have been replicated in ex vivo models, lungs, cells that have been stretched, ex vivo lungs, perfused and unperfused, animal models and human models, and I'll show you that. So I think that this phenomenon is a real phenomenon, a release of mediators due to injurious ventilatory strategies. Now, that's what happens in the lung, and again, because of time, I don't have time to go into a lot more detail about what happens in the lung, but I think what I'd like to focus on for the last 10 minutes is the potential systemic consequences of this biotrauma. And this is from a study we published about 7 years ago. David Cimello was the first author, and we used an acid aspiration model. Now we're using a model, an in vivo model. take rats, give them acid aspiration. This is a relatively common approach to acute lung injury. I think it's a relevant model. It mimics patients who aspirate. And we now used 4 ventilatory strategies shown on the left. Tidal volume of 16 ml with 0 PEEP, or 16 ml with 5 of PEEP. Then lower tidal volume, 5 ml per kilo, 0 PEEP, 5 ml per kilo, 5 of PEEP. And ventilated, and now just didn't measure just what's happening in the lung, but also measured what's happening in systemic circulation. And here are the results here. You can see that most animals had a relatively low levels of TNF that didn't change over time. One group had an increase in TNF over time from 0 to 4 hours. That was quite different than the other groups. That was this group here, the group with 0 PEEP and 16 ml per kilo. So these data showed, first of all, that how you ventilate can actually have an impact not just on what's happening in the lung, but can have an impact on release of mediators into the circulation. If those mediators then interact with end organs, you might get the development of multi-system organ failure. It also showed, as a number of studies, the protective effect of PEEP. Because here, if you look at this, these animals had 16 ml per kilo, the same as this, had high PEEP, so the amount of overdistension here was greater than the amount of overdistension here, and yet TNF levels were essentially unchanged in the high PEEP group. But the most important point is that ventilatory strategy can have an impact not just on what happens in the lung, but what happens elsewhere, and I'll get back to this point, which I think is an important one. Other studies, there's been a number of studies that have looked at issues like this. There's a study on pneumonia and the spread of bacteria, one from John Marini's group. I'm just showing one from Verbruge. The objective in this study was to examine the effect of various pressures, PEEP, Inspiratory, and PEEP, on development of bacteremia. They studied rats, given intratracheal instillation of Klebsiella, and ventilated them with various pressures, either 13 of peak inspiratory pressure, 3 of PEEP, 13 over 0, 30 over 10, and 30 over 0. And as you can see on the right here, the first 3 groups, the first 2 groups with relatively low peak inspiratory pressures of 13, not surprising, there wasn't very much of an increase in terms of number of animals with bacteremia. If you look at the far right now, you can see that the animals ventilated with 30 over 0 had a marked increase number of animals with bacteremia, and again, PEEP was protective. So here's another mechanism, release of bacteria. Now, many of our patients either have pneumonia or colonized. Release of bacteria into the circulation can cause, potentially lead to multi-system organ failure. A recent study from Seattle looked at the effect of mechanical ventilation on inflammation, lung injury, and extrapulmonary organ dysfunction. And they used a pneumonia model. This was published last month or the month before. And on the left here are some of the data. They took animals, gave them Staph aureus pneumonia, then either had them breathe spontaneously or had them or ventilated them. And then on the left, on this slide shown here, this is IL-6, another cytokine. If you look over here in the groups that were, this is the group, an increase in IL-6 in the ventilated group at 6 or 12 hours. This is the group given Staph aureus, but no ventilation. And here's the group given Staph aureus ventilated. And you can see IL-6 in the serum increased dramatically compared to this group here, showing basically what I showed you previously, but in a different lung model. And perhaps more importantly, when they looked at creatinine as a marker of kidney dysfunction, you know, many patients with ARDS or those who get multi-system organ failure, the kidneys are one of the first to fail. You can see creatinine levels in the ventilated group compared to the non-ventilated group with the Staph aureus. The creatinine levels were substantially higher and greater than the control group given PBS. So this group showed that in a pneumonia model, mechanical ventilation has an impact on release of mediators and has an impact on end organ function. What might be the mechanism of this increase in end organ dysfunction? Well, we set out to address this a few years ago. Yumiko Mai was the first author on this paper. This was a study to look at the impact of mechanical ventilation and injurious ventilatory strategies on cell apoptosis and organ dysfunction, and this was an experimental model which I'll describe. So we used a model here of anesthetized rabbits, again given intratracheal acid aspiration. So the animal were given acid aspiration to give you similar to the rat study I showed you before. They were then randomized into a low tidal volume group with high PEEP, that's protective, or a high tidal volume group and zero PEEP, that was not protective. And we made a number of measurements, including hemodynamics, various enzymes and cytokines, and then we measured something called apoptosis, that's programmed cell death, to give us an index of maybe this might be an early marker of potentially injury. Apoptosis doesn't necessarily mean injury, but we thought in this model it probably would. So here I'll just give you the results. First of all, blood pressure was essentially identical among groups because that's a key factor here. Does hemodynamics affect what's going on? And here is the kidney. This is what's called a tunnel assay. And this is an example from a non-injurious group animal and from an injured animal. And you can see here that these arrows point to these tunnel-positive cells. These are cells that are apoptotic, undergoing programmed cell death. And as you can see here that they're much greater in this injured group, than the non-injured group. Remember here that these studies are such that you have a non-injured group, that means lung injury, you've got acid aspiration or no acid aspiration. They're then ventilated with a protective or non-protective strategy, and we're looking at what's happening then at the kidneys. So we're looking at what's happening at the kidneys, but the impact is from what's happening in the lung, what we did with ventilation, because that's the only difference between the two groups. So here is the examples I showed you. If you look at the bottom on the left there, you can see a non-injurious group that the apoptotic index is relatively low. The injurious group, apoptotic index is very high. And if you look at the small intestine on the right, in the villi of the small intestine, we see the same thing. That didn't occur in the crypts. So I think this is important. So you can see on the right the small intestine, that the same occurred in the injurious group in the villi, but not the crypts. So the take-home message here is, what we're doing, as I said, is we're injuring the lung, we're ventilating with two different strategies, and that's having an impact not just on what's happening in the lung, but what's happening in distal organs. So that has implications, as you can imagine, for patients. Now, all of the data I showed you so far is from animal studies. Does this have any relevance at all to humans? And I think that there's a growing body of literature that, in fact, it does. And I'll just show you some of this data, and I've left off some data recently. So this is from a study by Ranieri and colleagues. We did looking at patients with ARDS, ventilated with a standard ventilatory strategy or a protective strategy. And here are the results. This is now neutrophils from the lung, from lung lavage. The control ventilatory strategy, you can see that these patients were ventilated for 36 hours. So entry, time 1, time 2, these are individual data. This is the average data. The mean data, you can see that basically there was no change, maybe a slight increase in the control group in the number of neutrophils, representing inflammatory response. Look what happened in the lung protective strategy. There was a decrease in neutrophils over time. So using a lung protective strategy decreased inflammation in the lungs of these patients. This is associated with a change in tumor necrosis factor alpha. Here at time 0, you can see that there's an increase or a tendency to an increase in the control group, and there was a decrease in the lung protective strategy. Other groups have shown this as well. This is from a study from Stuber and colleagues published in Intensive Care Medicine a few years ago. They took patients with ARDS and then used a relatively lung protective strategy, small tidal volumes, some PEEP, then changed them to a lower PEEP, higher tidal volume, and then went back to the protective strategy and measured a number of cytokines. And here are the results. You can see when they went from this lung protective strategy up to this low PEEP strategy and high tidal volume, that is relatively non-protective, there's a marked increase in some cytokines. This cytokine level, this was IL-6, went from 100 to about 500. This persisted, and when they changed back to a lung protective strategy, within 1 hour, cytokine levels decreased. So these data make an important point, I think. First of all, they show that what I talked about in animal studies appears to be relevant in humans as well with various cytokines going up and down, but it also showed that this can happen quite quickly. This is within 1 hour. You get changes in cytokines within 1 hour. This has tremendous clinical implications. So in terms of ventilating our patients, if you use an injurious ventilatory strategy, in terms certainly of the inflammatory response, even just 1 hour of sort of inappropriate ventilation can have a serious impact. And of course, there are other factors in terms of ventilator-induced lung injury. But I think that this is very important. We should try to keep our patients on a protective ventilatory strategy as much as possible. In terms of the implications for humans in terms of apoptosis, one thing I didn't have time to show you in that animal study from MI, we looked at something called soluble fast ligand, which is a pro-apoptotic factor, and showed that that was likely one of the causes, at least, of the apoptosis. So what we did was we went back to the Ranieri study that I mentioned to you and looked at those patients and looked at changes in plasma soluble fast ligand versus changes in creatinine. So the x-axis here represents this pro-apoptotic factor in the serum, and the y-axis represents, if you like, renal dysfunction. And you can see the greater the change in the plasma soluble fast ligand, the greater the change in plasma creatinine. So this at least suggested, it certainly doesn't prove, that this factor may be important for producing organ dysfunction, and specifically here, renal dysfunction. So this is all human studies. There's other data from the ARDS study looking at patients who went on to live and die, showing that changes in cytokines were greater in the patients who went on to die than those who went on to live. That's a large study of, as you know, of 861 patients. So what are the implications of this biotrauma hypothesis? Well, one of the implications is that besides increasing our understanding of what's going on, may represent an approach to develop novel anti-inflammatory therapies. So when we think about ventilation, we always think about biophysical factors. But now I think we have to start thinking about, well, are there immunological, are there biochemical factors that we might be able to target? And the reason I think this is potentially important is the following. You know, you can ask very naturally, well, do we really need these novel non-ventilatory, any novel non-ventilatory therapies? And I think I'll show you the one slide from Gattinoni's, a study by Gattinoni that I think suggests that we do. This here is taken from a study published a few years ago, patient with ARDS, CT scans, and they took CT scans at different slices, the dependent region, that's closest to the bed, if you like, to the non-dependent region. And they did this at different PEEP levels. And the y-axis here represents gas-tissue ratio. Just think about this as how much gas there is. And as I said, the x-axis represents PEEP. So look what happens in the dependent region, or let's start here in the non-dependent region. As you increase PEEP, hold on a sec. As you increase PEEP, there's a gradual increase in the gas-tissue ratio. In other words, more gas is getting in there, likely representing overdistension at the far right. If you look in the middle, this is what you really want to get with increasing PEEP. You've got areas that appear to be collapsed. You go to the inflection point or the lower inflection point, and at that point, when you increase PEEP, you now start to open up the lung, and that's the concept of how and why you want to use PEEP in these patients. And then the final, at the bottom, the bottom graph, you can see as you increase PEEP, you have no effect on gas-tissue ratio. It remains the same. The lungs stay collapsed. Well, just think about this. This is just 3 regions here. And how are you going to pick the right PEEP level? If you pick a PEEP level that's here to open up the lung, that's terrific for this middle region, probably leads to overdistension in this region, does nothing down here. So essentially, I'd say that in some patients, it just won't be possible. Their lung injury is so bad that it just won't be possible to develop a ventilatory strategy that's non-injurious in all lung regions. And I just showed you these 3 regions. Really, there's 300 million alveoli and less acini, but I think that this is the issue here. Now, you might be able to do some things, prone position, other things. Some patients, you just won't be able to develop a non-injurious ventilatory strategy. So in those patients, might say, well, what's killing them? If it is, in fact, this biotrauma hypothesis, let's target that. So we try to get the ventilatory strategy that's protective, If that's not entirely protective, let's then look at some other approach, and that's where anti-inflammatory mediators may be useful. So has that been tried? There's a study by MI published a few years ago in which she gave intratracheal anti-TNF antibody and showed how it can attenuate ventilator-induced lung injury. This was in rabbits. She used a lung lavage model. So animals were ventilated, were lavaged, removed surfactant, and you can see here that PO2 on the y-axis here, time on the x-axis. After the lung lavage, there was a marked decrease in the PO2 down to about 100. That's classical for this kind of model. And this shows the control antibody and saline control, no impact. When she used a low dose of anti-TNF antibody or a higher dose, marked changes in PO2. So these data suggest that using anti-TNF antibodies can have an impact not only on, you expect that cytokines might change, but also on oxygenation in a pretty dramatic way, from a PO2 at the end here of 100 up to a PO2 of about 450. So these data suggest that it might be possible to mitigate this ventilator-induced lung injury using anti-inflammatory approaches. So in conclusion then, I think ventilator-induced lung injury, as I discussed, can take on many forms, including barotrauma, volutrauma, atelectrauma, biotrauma. And there are other forms, as I said, you'll hear about in the next couple of days in terms of the effect of the circulation causing injury. I think that it's important to use protective ventilatory strategies throughout the ventilatory course of our patients. And this is particularly once the patient's in the ICU, being ventilated, monitored. We know this now, and most people are careful of that. But just think about the time you're bagging the patient with no control. You could be overdistending the lung. You could be causing serious injury in a relatively short period of time. There are a number of manifestations. As I said, biotrauma is one that is of interest to us, and I think is important because those manifestations can extend well beyond the lung. Other manifestations can as well, but I think it's a little more subtle. You may not see it. You don't see air leaks. You don't see air on chest x-rays. But this may be a cause of multi-organ dysfunction syndrome, may be a cause of death. I talked early on about how most patients with ARDS die not from hypoxemia, but die from multi-organ dysfunction syndrome. So this may be the link. And biotrauma does open up the possibility, potentially in the future, to use of novel anti-inflammatory therapy for patients in whom we just can't get a strategy that's protective, ventilatory strategy that's protective. So maybe a few years from now, as we're intubating patients and they're at high risk for developing biotrauma, maybe you'll squirt some anti-mediator down into the lung and use that or give it intravenously to try and protect the lung. But until then, certainly you should focus on using lung protective strategies. That's going to be a theme you'll hear about for the rest of the day. And I think it's very important because it can have a huge impact on survival in our patients. I didn't show you data from the ARDS study. I'm sure most of you are aware of that. That showed that a lung protective strategy can decrease mortality from 40% to 31% in patients with ARDS. So very important, not just in terms of physiology, not just in terms of publishing papers, but in terms of our patients. Thanks very much. We have time for some questions. There are a couple of microphones that are wandering through the hall. Just put up your hand, we'll get you a microphone. This question in the center here.
A few more words on what you mean by atelectrauma. You kind of breezed through that portion of it, and that's relatively a new concept.
So what I mean by, go ahead, Gary. What I mean by atelectrauma is there's data in the literature that shows if you let lungs collapse and then reopen, that can cause injury. So when you think about lungs collapse, that's atelectasis. So just developed this term atelectrauma to explain or to identify the kind of injury that can occur by lung units collapsing and then reopening. Why that might occur, the mechanisms by which it might occur, are when lungs are collapsed or hypoxic. I don't think that's the mechanism. I mean, we had patients with TB who had collapsed lungs for a year, for half a year. They don't get the injury. It can be effects on surfactant at low lung volumes. but could be also effects of, if you think about, certainly coming from Canada and from New York as well, if you think about if on a cold day, put your hand against some metal, dry day, and quickly remove your hand, how you can rip the epithelium on your hand. So it's possible that lung units that when they collapse, they stick to each other, you pop them open, and that can cause trauma. So that's what I mean by Atelectrauma. De-recruitment phenomena and a re-recruitment, that combination of re-recruitment and de-recruitment. It's hard to distinguish the two. Well, certainly the de-recruitment by itself, there's some evidence that just being atelectatic isn't what's causing the injury. You have to reopen the lung. I should have a caveat though, and Rolf Hubmeier actually had a paper in the Blue Journal questioning whether this Atelectrauma really exists. And I think that I'll let him speak either now or afterwards about this. I think a lot depends on the model you're using. And the data he used in general to say that, gee, maybe it's not a real phenomenon is lake acid. That causes a lot of edema. And if you have the lung full of edema, I don't think it's going to collapse and reopen. But there's certainly some cases when we used our ex vivo lung model, for example, there is no edema. I mean, because there's no, you take the lungs out and there's no more new edema added, the lungs definitely collapse and reopen, and you definitely get injury. What happens in vivo, in humans, we don't know. My guess is a gradation. There's some areas of Atelectrauma, there's some areas where there's a little bit of edema, and you have manifestations of all of them.
Thank you very much for excellent presentation and new information again. Jyrki Tenhonen from Tampere, Finland. Two patients, both have PEEP 12, both have perfect tidal volume per ideal body weight. One is on a triggered or a spontaneous mode, the other one is on controlled mode. Could there be a difference in, say, atelectrauma or say, inflammatory response in these two patients in terms of inhomogeneous lung?
So, very good question. The question I think you all heard was, controlled ventilation, mechanical ventilation versus someone triggering where their diaphragm is actually working, and that the distribution of ventilation could be quite substantially different in those two situations. And in fact, I think there can be a difference. We have a paper we're just ready to submit looking at actually pressure support ventilation versus controlled mechanical ventilation, showing that with pressure support, same tidal volume, same everything else, you get less injury, in fact, than with controlled mechanical ventilation. The concept here is that, as many of you know, when the diaphragm contracts, the distribution of ventilation in a patient who's paralyzed is largely a lot of the gas goes to the non-dependent regions on top. When the patient's diaphragm is contracting, you get the diaphragm contracting, you actually get some ventilation to the lower region. And that's actually a concept Charlie Bryan from Toronto, who just passed away last year, it was his original concept with Alison Fraze. So I think that's important. We don't know enough yet, but there's also some data with NAVA. We worked with Christer Sinderby. It's also a paper that's going to be ready for a submission soon, showing that also appears to lead to somewhat lower lung injury than simply controlled mechanical ventilation. There isn't enough data yet, but the small data I'm aware of suggests that, in fact, that hypothesis is probably correct, that the diaphragm contracting is probably a good thing. A question in the center? Actually, there's a microphone just coming, if you don't mind.
Pleasure to be here. Mike Champagne. I work down at South Florida. I was mostly very interested in the biotrauma work that you've been working on, and many other researchers have. I think it's definitely very sexy, and it's revealing a lot of things that been prior to this. I just totally missed it. One thing that struck me about some of the research, as you said, that you showed was that there was release of pro-inflammatory cytokines even marked even after an hour. It seems very striking to me, and that we usually think about in terms of 2 to 4 hours for de novo synthesis. Is there a thought that there's some sort of priming taking place there? And I have one other question along with that is, how much lung injury do you think, if you have resident lung injury versus from perhaps ARDS or a pneumonia or already an inflammatory mechanism or component taking place in the lung, is needed to incite some remote organ injury, as versus someone who might be healthy and we're already kind of starting them on maybe not such a healthy start on the ventilator?
Two great questions. So you're interested in trauma. I'm not surprised. You're from Florida with the hurricane season coming along there. We actually thought about having this in Florida, but we're a little worried about the hurricane. I guess there's one coming through Florida in a couple of days, huh? So the second question relates to the issue of biotrauma. Actually, give me the first one again. The first question just...
The first one was I think the striking rapidity of seeing some cytokine develop, seeing cytokines in the serum, seeing cytokines already there. Generally speaking, in the laboratory, we're looking at 2 to 4 hours for TNF alpha or IL interleukins or anything like that. This is 1 hour is really impressive.
Yeah, I was actually surprised at how quickly the serum cytokines appeared in that study. Now, but there are preformed cytokines, and they're likely quickly released. I actually thought it would take a number of hours. So when that study came out, but it was quite striking. And if you looked at this, didn't occur in just one patient; it was in multiple patients. So I think that this can occur relatively quickly. And I think you're right that there must be preformed, and priming is important. And in fact, that gets to the second question, your second question about pre-existing lung injury. The data I showed you were from healthy lungs, from those rat studies, healthy lungs ventilated for 2 hours ex vivo, and we showed this increase of cytokines. In vivo, we've not been able to take animals with healthy lungs and cause biotrauma in healthy lungs. We probably need such high tidal volumes that you cause hemodynamic implications. So I think it is a two-hit hypothesis, that you need something there to start with, and that when you have something there to start with, then adding a second hit causes release of cytokines. It's not likely to be terribly important in humans that have completely normal lungs to start with, unless you use crazy ventilatory strategies. Certainly over the time frame we're talking about. So I think you're right that, and this is more of an issue in patients who have diseased lung to start with. If you have healthy lungs, just think of how much to cause overdistension. There you can use 10 ml, 12 ml per kilo. You're not going to overdistend the lungs likely. If you have injured lungs and you have collapse, then a tidal volume going to a small portion of the lung can cause the overdistension. So I think in general it occurs largely when you've got a pre-existing lung injury of some type. Final question, then we'll have to get going.
Yeah, quick question. If the goal from a mechanic standpoint is to have small oscillations of tidal volume around a moderate lung volume, average lung volume, why have you apparently lost interest in high-frequency ventilation?
Good question. Actually, haven't really lost interest in high-frequency ventilation. I'm part of a group actually that's going to put in a grant for a large trial in high-frequency oscillation. Theoretically, at least, the way you summarize, you got it right on. Theoretically, at least, high-frequency oscillation should be the best approach for ventilator-induced lung injury. It stays away from the high end, the low end, and gives you the small middle ground. Most data to date haven't really confirmed that. They haven't not confirmed it either, but I think we need a larger study. And we're hoping to do an association with a Canadian group, Maureen Mead and Neil Ferguson, Tom Stewart, Deb Cook, to do a large-scale high-frequency oscillation trial in which we address this hypothesis with sort of enough power to look at the mortality endpoint. There was one study, as you probably know, DARDAC, showed a tendency to actually improve a decrease in mortality with high-frequency oscillation. Wasn't powered to show it. It was only 150 patients roughly. And also the control group was not as protective as we now use today. So I think theoretically it should be the best. We'll have to really test that out. And in fact, with high frequency, as you know, you end up using much higher mean airway pressures that are above sort of where you think you want to keep the plateau pressure, and yet patients seem to do relatively okay. So it's an interesting mode that needs a lot more work. So thank you very much. You can catch me at the coffee break if there's any more questions you'd like to ask.